So we have a lot to cover today. I just asked the team who thought it was a good idea to announce all of this stuff on the same day, and they said back to me, what was your idea? And they're absolutely right. What you're going to hear today is a mix of a lot of things. You're going to hear about research that the office has done in partnership with experts we've hired. You're going to hear about research that we're going to continue to do in partnership with the Brown School of Public Health. You're going to hear about legislation that we have proposed to stabilize our healthcare system. You're going to hear about litigation that we filed, I believe late yesterday, that's on file in Superior Court to take on an industry that has driven drug costs spectacularly high. And so we believe collectively, the team behind me, who I'll introduce in a moment, are really convinced that these are steps we can take now to stabilize our healthcare system. And then in the near long term, take the additional steps necessary to bring Rhode Island to a place where the system truly works for all Rhode Islanders. We are in a state today of spectacular failure that is literally occurring before our eyes. And while some, if not most of us, see it, the canaries are in the coal mine, which I'll get to. Somehow, when we go to 50,000 feet, we're not ready to treat the problem as seriously as it is, and in a sense, suffer the pain it's going to take to fix it. Okay, so I want to introduce a team that's really worked hard on healthcare. Standing behind me are, among others, Keith Hoffman, who is our Chief of Policy. Keith's over here. Sarah Rice, who is the Deputy Chief of our Civil Division. She is in charge of our Public Protection Bureau. Sarah's right here. Many of you know Sarah from her work on a whole host of other things that we're doing. Stephen Pravaza is the Chief of our Consumer and Economic Justice Unit. Steve's right there. Lee Staley is the Chief of our Healthcare Unit, and Lee is here. Dorothea Lindquist is a Senior Litigation Attorney in our Healthcare Unit, fine litigator and policy expert. Julia Harvey is our Healthcare Advocate by statute. Where's Julia? She's right there. She knows more about healthcare than I can ever hope to. Jordan Broadbent is where? Where's Jordan? There she is. Jordan is our Insurance Advocate. I think Jared Page, is Jared up here? Or Jared is out there. Jared is our behind the scenes paralegal who keeps everything running. Before I begin too, I want to thank, you're going to hear about legislation that we've introduced. One piece of legislation is intended to stabilize primary care in particular. And that is sponsored by Pam Loria in the Senate and Megan Cotter in the House. We have prior authorization legislation that I'll discuss, really prior authorization elimination legislation that is sponsored by Mia Ackerman in the House and Senator Murray in the Senate. And we also have a amendment to our Hospital Conversion Act authority that is sponsored by Susan Donovan in the House, and we're waiting for a Senate sponsor. And I see a real champion of healthcare in the back, Senator Tacoyan, who I've known for a very long time, back in our U.S. Attorney and State Police days, and he's gone on to be a fine leader, particularly in healthcare, Senator. I appreciate your work in moving healthcare forward and our conversations about it. So how did we get here? And one of the things that I've said as I've spoken about healthcare is, why should anyone in Rhode Island listen to a group of lawyers when it comes to healthcare? My wife might say the same thing, as she is in healthcare, as is my son. And I will tell you that the reason why, what the team is going to share with you, and they're going to speak to you directly about some of the things that we have done and are proposing to do. They are not lawyers doing healthcare. They're healthcare lawyers, and there's a difference. When I got here in 2018, really 2019, one of my great concerns even then was how the state was going to address our looming healthcare crisis. It was looming then, it's here now. And I was worried for a couple of reasons. Number one, I didn't know a whole lot about healthcare. I've been a federal prosecutor for most of my career. And we had seen, before 2018, some significant problems in the healthcare space. Rhode Islanders are familiar with the closure of Memorial Hospital and the impact that that had on the Miriam Hospital emergency room. That continues today. Because of the St. Joseph's pension plan implosion following the 2014 sale of Charter Care to Prospect, we saw the fallout with labor. Healthcare workers, nurses who are concerned about whether they would receive the pension that they were promised. And in fact, when I was running in 2018 on Halloween, I had a conversation with someone that has stayed with me to this day. And that is, I was with Senator Whitehouse in Johnston for an ice cream social. We were both running for office. And as I was leaving, there was just someone standing next to me as I was heading out the door. And this person was a nurse. I asked her, what she had done, and she told me she'd been a nurse for decades. It was a long time. I don't remember the exact number of years. And I asked her how long she had been living in, Johnston subsidized housing, and she told me just for a short period of time. And I asked her, what brought you here? And she told me then that she'd been a nurse at St. Joseph's, and she'd been worried about her pension and felt like she needed to sell her house to get ahead of any issues she might have with that pension. And that conversation has stayed with me since that day. When I thought about healthcare, and I think about then, and I think about healthcare now, what I said to myself was, it's not going to happen on my watch, or at least I'm going to do everything I can as Attorney General to make our healthcare system as strong as we can possibly make it. And so here we are with a really great team that's going to share what they found with you today. So I want to just, though, set the table for what the problem is and how I came to be convinced not only of what it is, but the things that we need to do to solve it. So I think it was in 2020 or 2021, Prospect came to the office and they wanted to have a change of ownership regarding Roger Williams and Fatima Hospital. And ordinarily that would, I think, in the past at least, have been something which would have caught particular attention. It wasn't like they were selling them to some other company. They were 60% owned by a private equity firm. This is a story that Ian knows, and Richard knows, and many of you know. And I go over it just to set the table for where we're going. So it was owned by 60% by a private equity firm, Leonard Green, and 40% by two gentlemen, Lee and Topper. And all we heard in the run-up to that sale was what a great job Lee and Topper were going to do. There was an agency that, for whatever reason, escapes my mind, the Health Services Council, I think is the name of it, that approved the sale. We heard from elected leaders about what a great thing this would be for Rhode Islanders. But when we got into the books, what we saw was something very different. What we saw was a company run by a private equity firm that had driven the hospital businesses, because it was a business, they owned 17 hospitals, had driven them into the ground. They had gone from a company that could support their hospitals in a state of need, like Roger Williams and Fatima were, to a hospital system that could not. And they'd done that by taking out $1 billion in loans, putting the money in their own pockets, and taking out a lot of debt on these hospitals. And so the question, not on our hospitals, but on the big company itself, okay? And so what that meant was that Prospect could not support our hospitals. And so I had to deal with the question of, if Prospect's not there to support these hospitals, can they make it? Can Roger Williams and Fatima Hospital, and Lynn knows this very well, as does Chris Colaci, who's not with us today, but you guys in particular know this story very well. Can they make it on their own? Can they make it on their own if Prospect's not there to support them? And what we found was that they couldn't. They couldn't, and they hadn't been able to do that. In fact, it was one of the reasons why Leonard Green wanted out, because they couldn't make money in healthcare, so they took a loan out and pocketed the profits and wanted to get out. And if there's ever a story, and this is before Stewart in Massachusetts, if there was ever a story that told us why private equity does not belong in healthcare, that was the story. And so to make a longer story very short, what we saw was they weren't making enough money, our hospitals, through reimbursements, which is how you get paid in healthcare, weren't making enough money to pay their operating expenses, meaning stay in the black on what their bills are every year, let alone invest back into their hospitals. And that had been the case for years. And so the question became, what's going to keep these hospitals open if Prospect is gone and Leonard Green, which is the deep pockets, are gone? Are Lee and Topper going to keep them open? We were told Lee and Topper are all in on this, but the team didn't buy it, and that's where the money in escrow came from. That's why we had that pitched battle over that $80 million in escrow, because we believed that money was necessary to keep these hospitals open. And so we conditioned it on, we conditioned them getting the money back, meaning Leonard Green, because they put money in the pot even though they were gone, they didn't get it back unless they kept those hospitals open. Now they're in bankruptcy today, and we'll talk more about that. But that's where I learned that there's a problem in healthcare, a structural problem that's going on here. And what is it? Our reimbursements are too low. They're too low in Medicare, they're too low in Medicaid, they're too low in commercial, okay, relative to our neighboring states. And some of our hospitals, like Roger Williams and Fatima, have a very high Medicaid and Medicare mix. It was about 70-30 Medicare and Medicaid, governmental, to 30% commercial. Now, if we can go to that slide, folks, that my friends here that are working with me, which shows, we'll get to Barletta in a minute, this one here. So this shows you why having a large Medicare and Medicaid population really impacts your revenue. So Medicaid reimburses at 37% of Medicare. Commercial reimburses at 200% of Medicare. So Medicare is the benchmark. So what that means is that if somebody walks in for a hypothetical service, let's say a physical, okay? And if you're a Medicare patient, meaning you're an older American, you're covered by Medicare, you walk in, that physician's gonna get reimbursed $100 for that physical. If you're a Medicaid patient, that physician is gonna be reimbursed $37. If you have private insurance, you're gonna be reimbursed as the doctor $200. So when you have a lot of government insured people in your pool, like Roger Williams and Fatima do, 70%, for the services you provide, you're gonna get less revenue. That's the fundamental problem that we have in Rhode Island. And it's not much better at our other hospital systems. It's about 65, what's the delta there? 65-35, math isn't my thing, that's why they're here. 65-35 for places like Brown Health and Care New England. And frankly, I was expecting it to be much better than that, and it's not. And so, so what's the lesson? What's the lesson? The lesson is we need to raise our reimbursement rates. And look, this is not something that we need to study. We know this. We know it, right? This is not going to take 2, 3, 4 years to figure it out. We know that revenue and reimbursements are the problem, and we know it today. We know it because when we reviewed the proposed merger between Care New England and then Lifespan, now Brown Health, by getting into their books, which we did to evaluate that transaction over a number of months, we know that our Medicare, Medicaid, and commercial reimbursement rates are lower relative to our neighboring states. We know it from the Rhode Island Foundation report, and credit to them for putting that report together. We know it, I know it, from talking to doctors and providers all across the state. There's a doctor, Patrick Sullivan, he's a retired plastic surgeon. Is really an impressive guy. He spends around 6 months of the year repairing cleft palates for free in the Far East, in Vietnam and Cambodia. A really terrific guy, really believes in giving back. And he brought a group of all kinds of doctors in here. We met in the room behind us. And we talked about what it was like to practice as a thoracic surgeon, as a cardiologist, as a pediatrician, as a primary care doctor. as a dermatologist. And here's what we heard. We heard that if you're a primary care doctor, the attraction of concierge medicine is hard to turn down. You work less, you get paid more. What does that mean? That means you're not taking insurance. It also means that a good chunk of Rhode Islanders don't have access to those services. So if all of our doctors go to concierge medicine, that's a problem, because a lot of us can't afford to pay out of pocket for that doctor. We learned that for dermatology. There was a dermatologist there. He has a practice in Seekonk and a practice in East Greenwich. He makes 30% more doing the same thing in Massachusetts. I mean, we heard the same thing over and over and over again. Senator Ujafisa is here. She is a champion of healthcare reform. Her husband knows more about healthcare reform, Dr. Mark Ryan, than almost anyone I know. They arranged for me to speak to the Rhode Island Medical Society and the American College of Physicians Rhode Island chapter just, I think it was last week, although the weeks run together. It was last week, wasn't it, Senator? Thank you for being here. And what I heard there were the same things that we're talking about today. That they're primary care doctors that want to stay in the game. They believe in what they do. They love their patient panel. It's the way my wife loves her patient panel. But they are overworked, and there aren't enough of them, and we're not attracting new doctors, and that primary care population is aging. You know, I think the way you learn about any problem is to get out into the field and see it. I had a property professor at Boston College Law School. His name was Zig Plotter. This character. But what he told us was, when you buy your first home and your second home, walk the land. Get out there and see what it is you're buying. In today's market, I don't think people are even going to the property before they buy it. I walked my land when I bought my first and only home. But the point is, the way you learn about anything is seeing it, feeling it, touching it. And when you visit these places, like, you can feel the crisis. I know Lynn feels it. You're there every day. Lynn Blaze is a nurse, and she is a leader of UNAP, and a friend, and someone who has taught me a whole heck of a lot about healthcare. Pat Crowley's taught me about healthcare. Patrick Quinn has taught me about healthcare. Mike Wagner has taught me about healthcare. Mark Ryan has taught me about healthcare. I visited Kent County Hospital. I've been out to Landmark and met with their physicians. And what you see when you go there is great providers. The workers are spectacular, but there aren't enough of them. The physical plant. I visited an ER where the ER physicians and the other workers are working really hard, but the ERs are rabbit warren. It's not open. Like, for those of you who've watched The Pit, it doesn't look like The Pit, okay? It doesn't look like the ER at Barnes Jewish Christian Hospital in St. Louis, where my son went to med school. It doesn't look like that. You can't see everything from there. So you have 6 teams all working individually because you can't work together and you can't leverage because the physical plant doesn't support it. Where behavioral health patients are kept, looks more like a jail cell than an ER space. There's a hospital in Rhode Island where recently someone went in who had a significant problem with their brain. They had a brain aneurysm. And the hospital that this person went to couldn't get an MRI at that first hospital because the MRI machine wasn't working. I mean, you can see it in the eyes of Rhode Islanders who I speak to, and I speak to a lot of them these days about a lot of things. They're interested in the work of the office. When I ask them, how many of you can't find a primary care doctor? A lot of hands go up. So we see it, we feel the crisis all around us, and we don't need more studies. Some of the things I just talked about are the canaries in the coal mine, but there are others. There are others. Brown Health bought 2 hospitals. Everybody in this room knows, I think, where they were. They were in Massachusetts. Think about that for a minute. Brown Health buying 2 struggling community hospitals in Massachusetts. There are struggling hospitals right here in Rhode Island. Why are they buying them in Massachusetts? Because the reimbursement rates are higher. It's always about the money. Don't let anyone convince you that it's not about the money. It's always about the money. It's always about the economics. People make, for the most part, economic choices. And Brown Health made an economic choice that because they get reimbursed for every patient who walks through that door in Massachusetts, whether it's Medicare, Medicaid, or commercial, because they get more money, those patients are worth more than Rhode Island patients. You know, doctors are moving to Massachusetts and Connecticut because they can make more. I'm absolutely convinced that if Brown Health could pick up Rhode Island Hospital and move it to Seacon, they would. But you can't move a hospital. You know, it's not a question of what the problem is. It's a question of what are we going to do about it. And in particular, what are we going to do about primary care? You know, the office, you'll hear more about it, but when the office did a survey of Rhode Islanders for an insurer, for Rhode Islanders insured by a particular commercial insurer, as to whether or not they could really find a primary care doctor, when we studied that problem by calling, we literally called every practice within 30 miles of Providence and asked whether we could get an appointment for a state worker covered by this insurer. 51% of those practices that the insurer held out. At the time, they say it's improved since, but at that point in time, 51% of those practices weren't taking new patients, and the ones that were offering appointments 3, 6, 12 months out. So there's no question that we have a problem. And so the question really becomes at this point, you know, what are we going to do about it? And so we're here to talk about that today, and I'm going to go through that really quickly now, and then the great team behind me is going to put a little more meat on the bone, if you will. You know, we really started rolling out what we're doing last week with the Barletta settlement. You know, one of the questions for us was, and the team that worked on that case, the criminal division team that worked on that case, worked incredibly hard. I mean, you don't recover 10 times what the federal government recovered, you know, 18 months later without working really hard and convincing Barletta we were prepared to take that case to trial, and we were. So they worked hard. I think Barletta, you know, had heard that they were in the bunker preparing witnesses for, you know, for 4 or 5 months. But in any event, the question was, what do we do with that money? And how do we solve a problem? When I was U.S. Attorney, one of the things that stays with me was President Obama challenging us to be community problem solvers. That was his challenge to us. That we'd be more than prosecutors, we'd be community problem solvers. Harder to do in the U.S. Attorney's Office, much easier to do here, because we have much more authority. There is no mothership other than the voters. And so, who I answer to, and we answer to. And so how do we reward their confidence in us by being community problem solvers? But here's how. When I read a story by Johnny Williams in the Providence Journal about a girl in the Providence school system, a young girl, who needed all of her bottom teeth extracted, it told me we had a community problem. And then the question is, I mean, that story was last June. The question was, what have we done since last June to today to address that problem? And I would tell you, government has done nothing that I'm aware of. And so it became very clear to me that if we had this pot of money and we could use it to drive it back into those neighborhoods to at least address that community problem and hope to solve it, then that action would make a difference. And everything we're going to roll out today is action that we believe will make a difference. So, yesterday, last night, we filed suit against the 3 largest pharmacy benefit managers in the country. And they are CVS Caremark, Express Scripts, and Optum. And we did so to protect Rhode Island consumers from unfair, deceptive trade practices that has caused drug prices to skyrocket. We know we have to do 2 things to fix our healthcare problem. We've got to drive more revenue into the system. We've got to bring costs down. And the cost of drugs is astounding, as you're going to hear today. And the reason the cost of drugs is astounding, as we allege, is that pharmacy benefit managers, PBMs, which is something that I didn't know a lot about, I suspect most Rhode Islanders don't know about or fully understand, because they operate in a very secretive and shrouded way. But what they do is this. We allege that they effectively extort manufacturers of pharmaceuticals through a rebate program to drive prices up. And when those prices go up, the PBMs take the profit. So effectively, because they have 80% of the market, they're able to use that market power to drive drug prices sky high and keep that difference. So before there was a cap on insulin, when we were looking at insulin and the way insulin had shot up in price, where was that money going? It's going less to the manufacturers who are playing ball, and they shouldn't, but they are. But that money was largely going to PBMs. You know, drugs that cost $22 in Denmark cost thousands of dollars here. We allege because of the PBMs. We allege that the PBMs, because of what they do, are driving independent pharmacies out of the market, including a pharmacy in my own hometown of Jamestown, which is something that is alleged in the complaint. So this is action that, if we are successful, and I expect that we will be, will drive down drug costs in Rhode Island and elsewhere. So that's number one. We have introduced legislation, and again, I thank the sponsors, to immediately raise Medicaid reimbursement rates for primary care to 100% of Medicare rates. So raise Medicaid rates, remember, 37, to raise it to the $37, 37% of Medicare, to raise it to Medicare immediately, okay? So, and to drive it into primary care. So some might ask, well, why primary care, why now? Well, there are other bills before the General Assembly that, if passed, could accomplish this, provided the money was driven to primary care. I'm speaking about the hospital legislation, the Harry bills that are in there. But I don't know if those bills have much momentum. But I know this, we have to stabilize primary care right now. Primary care doctors are the air traffic controllers of our healthcare system. They're the ones that analyze our problem, send us to the tests we need, send us to the specialists we need. We have to assure that part of our healthcare system up, and we believe that this will help do it. We've also introduced legislation to immediately eliminate 100% of prior authorization requirements for primary care providers. Not 20%, 100%. Primary care doctors spend too much time getting authorizations for things that get authorized in the end. So it's just overhead and frankly, frustration that is driving doctors, primary care doctors, out of the market. And providers as well, advanced practitioners. We are introducing legislation which authorizes this office to petition the Superior Court to place a hospital into receivership if the facility becomes financially unstable. So this is something, frankly, that we talked about with Prospect before we got to where we are today. I mean, as we could sort of see the ship headed for the shoals, we talked about whether or not we could get them reinvented here in Rhode Island and frankly avoid a bankruptcy proceeding elsewhere. We didn't have that ability to do that because it's not in our within our authority. But Prospect is a good example of why that authority might be necessary. This office has the ability to issue regulations like all agencies, and we are issuing a proposed regulation that would require a pre-merger notification of certain medical corporate transactions, including medical practice groups, including transactions involving private equity firms. One thing that we know we don't know is the level of private equity intrusion into the healthcare market outside of hospital systems. We have great insight into hospital systems because of our regulatory authority over hospital systems, but not into healthcare practices. And we believe that we need to know so we can head off any problems we need to know when those transactions are occurring. We're also issuing an advance notice of proposed rulemaking regarding market oversight of artificial intelligence. And Keith Hoffman's going to talk about that because it's a little above my pay grade. But AI is everywhere, and we want to make sure we understand how it's affecting healthcare, and if necessary, if it requires additional governmental oversight, we want to be positioned to do that. We are also issuing today, you'll have it, a report. Everything that we study and we have prepared will be publicly available. We're rolling out a new website, which will you'll be able to link to these documents. One is an HMA report, which we're going to discuss in a minute, study things looking backwards. But we're also going to collaborate with the Brown School of Public Health for Advancing Health Policy Through Research, CAFR. And what we're going to do there is examine whether or not more fundamental change to how we insure Rhode Islanders is necessary. So what does that mean in English? Well, we're going to take a look at how single payer might look if we were to go in that direction in Rhode Island, and give the General Assembly options should they choose to go down this path. One thing that we've learned collectively here is that whatever we're doing, it isn't working. It's not working for Rhode Islanders. And change around the edges is not going to fix it. And so this is something that we hope to have done soon. I have an incentive to get it done quickly because I'm in the latter part of my second term. So I hope that this will move quickly. We have a preliminary document study that we're going to release today as well from CAFR, and you'll have access to that, and we'll be spending some time talking about that. And then finally, there are a few other things that the team will talk about, but the team has long believed that one of the challenges here is that the way our state agencies approach healthcare is too siloed and too splintered. So we have OHIC, which does a good job in their lane. We have the Medicaid office, which is part of EOHHS, and then we have the Rhode Island Department of Health, and I may be missing another agency. We really believe that we could build a state agency without much, if any, additional cost that would deliver more and be more helpful to policymakers, and through policymakers, Rhode Island, something more akin to what happens in Massachusetts, where there is a dedicated agency that studies healthcare, gets the data they need to make recommendations, and then in turn makes those recommendations to policymakers. As I said, we have come to the conclusion that the way we're doing healthcare isn't strategic. That element of thinking doesn't exist in Rhode Island. I think much of what we do have exists here, and that is not ideal, frankly. This is a topic we've warmed to, but we can do better with a dedicated agency to look at these things. So that is sort of a very long overview, and now I'm going to turn it over to Dorothea Lindquist to talk about the first of these provisions, and perhaps a little bit more, which is the HMA study, which looked at, among other things, hospital utilization, long-term care, and primary care. So Dorothea, the podium is yours.
Thank you. As the Attorney General mentioned, I'm going to speak to you about the report that our office commissioned in October of 2023 with Health Management Associates, otherwise known as HMA, to evaluate capacity of hospitals in Rhode Island, the capacity of long-term care facilities, and in this context we're talking about nursing homes when I say long-term care, as well as the sufficiency of primary care providers across the state. So this evaluation that was undertaken by the office included dozens of interviews of key community stakeholders, leaders, and partners in healthcare across the state, and an analysis of the best data that was available at that time. The full report is, as has been mentioned, on the landing page of the Attorney General's website, and I'm gonna review a few key takeaways and findings with you here. But of course, you can always dive deeper into that report if you want to visit the website. No one who has worked in healthcare or who works in healthcare now is going to be surprised by any of these findings. As the Attorney General has mentioned, this is a recitation of things that we have all seen and felt and experienced throughout our experience in healthcare in Rhode Island, whether as patients ourselves or through the experiences of our healthcare providers. The takeaways that we want to emphasize here are threefold. Number one, Rhode Island is an outlier in key aspects of our healthcare delivery system. The second is that these negative trends that we are seeing are not going to reverse themselves. And the third is that what we really need in our state is a comprehensive, dedicated focus on healthcare reform that is supported by accurate, appropriate data. So there are 4 key findings in this report, and I'm just gonna list them ahead of time and then talk about each one of them in a little bit more detail as we run through these slides. So the 4 key findings have to do with, number one, there being a substantial mismatch between hospital capacity and need, and that is driven in part by workforce challenges that have been experienced throughout our healthcare system. Number two, that emergency departments are overburdened, and this directly impacts patient care on every level across the healthcare delivery system. Number 3 is that our long-term care, our nursing homes in the state are in big trouble, and we'll talk about why that is. And number 4 is that we know we have a primary care workforce shortage, but available data at the time of this report about primary care is not aligned with the lived experience of people in this state. So we'll talk first about hospital capacity. What we are seeing in this report is that the average daily census, that's how many people are in hospitals on a given point in time, of Rhode Island hospitals in 2022 was only 62% of the total number of licensed beds in the state. So at that time, this report is telling us that our hospitals are being underutilized. Our hospital leaders who were interviewed in the course of this project underscore the impact that the ongoing workforce shortages have had and continue to have on their ability to hire and retain nurses and other skilled professional staff. If hospitals are not able to recruit and retain a robust workforce, their ability to put people at the bedside to staff these beds and to serve the patients will continue to be limited, as we see it is in this report. We're seeing through this report that Rhode Island's hospitals are in economic distress, the drivers of which are many, which are complex, and which need to be better understood in order to accomplish the course correction that is undeniably needed. Moving on to the second finding, which pertains to our emergency departments. Our emergency departments in Rhode Island are incredibly overburdened, and this directly impacts access to patient care. There are 3 key and related findings within this commentary on emergency departments in this report, and they are as follows. First, Rhode Islanders are seeking more emergency department care than nationally. So we are seeing 441 average visits per 1,000 people compared to 411 visits nationally. The second is that Rhode Islanders are leaving the emergency department without being seen at double the national average. And the third is that Rhode Islanders are spending more time in the emergency department than is the national average. And these findings are connected to hospital capacity findings. So if hospitals don't have staffed inpatient beds for patients to go into when they leave the emergency department and are admitted to the inpatient section of the hospital, patients are then boarded in the emergency department. That's the term of art that's used in the healthcare community. Boarding in the emergency department, in other words, when you are simply held as a patient in the emergency department, even though you have sort of been discharged from the level of care that is available in the emergency department until your bed opens up somewhere else in the hospital or in another hospital in the state. That creates a huge problem, a multitude of problems for patients and for the people who care for them. And this is happening in our state very, very, very often. Sometimes the medical record in the emergency department is not the same as the medical record on the inpatient side. So physician orders for medication, for example, can't be accessed or acted upon until a patient has been physically discharged out of the ED and admitted into the inpatient side of the hospital. So those treatments have been ordered, those medications are sitting there in the computer system waiting to be delivered, and they can't be because the patient hasn't been physically moved. Boarding also means, of course, that the emergency department beds themselves and the staff in the emergency department are tied up with patients who've already received all of the care that they can get in the ED. So there's literally no physical room for patients to be seen and treated in the emergency setting who are waiting in the waiting room, which you might understand would cause people to leave the emergency department without being seen, which is what this report indicates. Hospitals and staff there do the best that they can, and we literally owe our lives to them. But patients lying in stretchers in hallways is no longer a thing that you only see in movies or war-torn environments. This is happening in our state, all over the state, all the time. And we really need to fix this broken system, both for those who are trying to take care of us and for literally every single one of ourselves. We understand that the high levels of ED usage may also be directly connected to inadequate access to primary, that is routine, preventative, maintenance kind of health care. When patients lack this type of care, primary care, this leads to avoidable emergencies. And patients will and do seek emergency department services for care that could and should have been prevented and managed in an outpatient setting. So it gets worse. With respect to long-term care, and by that I mean nursing homes, this report shows us that long-term care is in serious trouble in Rhode Island. The key findings in the HMA report related to long-term care include a decrease in long-term care access, and that is due to the closure of many nursing homes and the workforce challenges. 87% of Rhode Island's nursing homes are for-profit entities, which is higher than the national average, and reimbursement rates to long-term care facilities remain unsustainably low. Over the past 10 years, a significant number, 9 nursing homes in Rhode Island have closed, which is 11% of our total facilities, just in the past decade. Our nursing home closure rate in Rhode Island is more than double the national average. Further, in April of 2024, 83% of certified nursing home beds in Rhode Island were occupied, which is a significant drop from 92% occupancy in 2015. Even worse than hospitals, nursing homes are experiencing a persistent workforce shortage in the long-term care sector in Rhode Island. And like with hospitals, this is a direct contributing factor to low occupancy, which in turn has significant implications for the financial sustainability of these facilities. Since this analysis was completed by HMA, we know that an additional facility closed last summer due to financial challenges. The financial distress of nursing homes in Rhode Island is compelling. Nationally, nursing homes rely on a payer mix that is heavy on Medicare patients to compensate for low Medicaid reimbursement rates. Enrollment in Medicare Advantage, which is an alternative to fee-for-service Medicare, is greater than 50% of the Medicare eligible population nationally and 56% in Rhode Island. The 4 insurers offering Medicare Advantage plans in Rhode Island have not increased their payment for post-acute care in a decade, leaving rates too low to cover costs in nursing homes. This finding should be terrifying to everyone in Rhode Island who plans to find themselves aging here. If this trend continues, even for a little while longer, there simply won't be facilities available to care for us, for our loved ones, when we need it. For those of us not needing this type of care personally or right now, well, this situation still is harmful for every one of us. Insufficient access to long-term care directly impacts hospital capacity. When there are fewer or no long-term care spaces which can receive patients being discharged from hospitals, they stay in the hospital, putting a greater strain on the emergency department because fewer beds are opening up, etc. It keeps beds occupied, increasing the bottleneck, and we're right back to where we started. And finally, primary care. This report shows us that primary care access is misaligned with our lived experience in Rhode Island. National data and our own licensure data here in Rhode Island compares favorably to national statistics for primary care providers. The Centers for Medicare and Medicaid Services, otherwise known as CMS, as cited in the HMA report, estimate that Rhode Island has over 3,000 PCPs. We know this is a clear disconnect. And since this report was finalized, researchers led by Dr. Caroline Richardson and Brown Medical School examined data from the All-Payer Claims database and estimated that the number of practicing PCPs in Rhode Island is significantly lower than that 3,000 number. They've estimated approximately 660 primary care physicians in Rhode Island. These data discrepancies underscore the need for better data reporting and analysis in our state. And you'll hear more about that in a few minutes. HMA's analysis also shows us an uneven distribution of licensed PCPs across the state, with the northeast and southeastern parts of the state disproportionately underserved. This slide reflects the study that the Attorney General referenced conducted within our office, where more than half of the 507 providers were contacted were not accepting new patients at that time. In closing, on the HMA report, these findings make clear that the serious workforce shortages across the spectrum of care are impacting every single aspect of patient care, and without robust real-time data analysis and policy solutions, we will not be able to course correct. And I will pass the podium.
Thank you, Dorothea. So I think what we've heard is plenty of really excellent information about the scope of the crisis, the scope of the problem, the nature of the problem, it's a multifold problem, and thought that was really eloquently encapsulated in the HMA report, which can be found online. The team is going to turn to talking about some of our action items. If you could go to the next slide. We'll start with legislation, and specifically I'm going to reference and speak to the Medicaid primary care legislation. Thank you, appreciate it. Thank you. So we'll start with Medicaid primary care rate increases, and then Jordan Broadbent is going to speak to the prior auth legislation. So according to a 2023 survey by the Kaiser Family Foundation, nearly 12% of adults in Rhode Island reported that they do not have a personal healthcare provider. And when you look at the census data in the state, that equates to roughly 100,000 adults. In recent months, we have seen increasingly dire signs that Rhode Island's primary care system is in jeopardy. The closure of Anchor Medical and the spate of challenges faced by our community health centers, these are symptoms of a lack of investment in primary care. Our office stays closely engaged with the primary care community, and when we speak with PCPs, one of the consistent messages that we hear is that Rhode Island Medicaid reimbursements are too low to ensure that Medicaid enrollees have access to care. And the Attorney General spoke to this when referring to the disparities in payment between Medicare, Medicaid, and commercial insurance. The stark disparity in payment rates impedes access to care for the more than 317,000 Rhode Islanders who rely on the Medicaid system, exacerbating their health risks. And this is just a downward spiral that can lead to avoidable hospitalizations and lost productivity. Low Medicaid reimbursement also undercuts our primary care providers by undercompensating them for their services, and it makes it harder for Rhode Island to retain PCPs. All Rhode Islanders bear the cost of failing to invest in primary care, and by the same token, investing in Medicaid primary care providers benefits our system as a whole. So that's why today we are announcing legislation that would immediately increase Medicaid reimbursement rates for primary care providers in Rhode Island. And I just want to thank our sponsors for supporting that legislation. Why are we taking this step? When we examine the reimbursement rates for common primary care services, one thing that stands out is that these rates are often a fraction of what Medicare pays, and we heard about that earlier, comparing the $100 service to the $37 reimbursement for the same service. The bill we are announcing today would increase Medicaid payment rates for primary care services so that they are at least equal to Medicare's payment rates. And increasing the state's Medicaid investment here would allow for the state to leverage federal matching funds that are available in the Medicaid program, essentially letting the state's dollar stretch further. What sets this bill apart from others is that it would channel higher payments directly to PCPs through higher rates. This is a targeted approach that also includes investments in our community health centers, which we think is critical. We think that this is the best way, and there's plenty of data to support this, the best way to ensure that our Medicaid investment flows to primary care providers. We look forward to working with our colleagues in the General Assembly to ensure this legislation receives consideration. And before just turning it over to Jordan to speak to our prior authorization legislation, I just want to mention that our office has also been advocating directly with insurers, private insurers, to take additional steps to address the access to care crisis in primary care. And we are currently in discussions with Blue Cross Blue Shield of Rhode Island and are working with them to identify additional opportunities to shore up our healthcare system in Rhode Island. We hope to announce further measures in the coming weeks.
Hello. As Lee previewed, I'm here to talk about our prior authorization legislation that we submitted to the House, but I want to do a little bit of table setting about why this legislation matters and what kind of prior authorization is and the burden it places on our healthcare system. Prior authorization is a requirement that health insurers place on providers to obtain prior approval before these providers can treat their patients and receive payment for that treatment. It creates an unnecessary burden on our healthcare providers, stands in the way of patient care, and replaces clinical judgment with profit goals. It's also contributing greatly to our state's diminishing workforce of dedicated healthcare providers by increasing and contributing to burnout. In 2024, the American Medical Association conducted a survey of providers across the country about how prior authorization impacts both their treatment of patients and their work lives. It found that on average, physicians and their staff report spending 13 hours a week on prior authorization. That's time spent away from patient care and on paperwork. In addition to negatively impacting the time and resource commitment of providers, it also leads to unnecessary spending and significant cost for our healthcare system. The same survey found that 73% of providers reported that prior authorization process resulted in additional office visits. 47% reported that immediate or emergency room care visits resulted from prior authorization, and 33% reported hospitalization. That type of utilization burdens our healthcare system and increased costs. It also delays a patient's access to the care that their treating provider deemed necessary. So, we believe that it should be a provider's decision on how their patients get treated, which is why we submitted to the House, with help from Rep. Ackerman, the Rhode Island Prior Authorization Reform Act. This is a bold and innovative policy that would prohibit insurers from requiring prior authorization on any test, treatment, procedure, prescription drug ordered by a primary care provider. There are limited exceptions with this bill. There would still be prior authorization requirements for controlled substances or for individual providers with documented cases of fraud, waste, and abuse. This type of bill would make Rhode Island a policy leader in the prior authorization space. It is a response to the cries for help that we have heard from primary care providers. You've heard a lot today about how we are in crisis, and this is directly responding to a call to action. We are asking the General Assembly to force insurance companies to do more, to eliminate all prior authorization requirements on our primary care providers and place care decisions with their primary care providers and not with insurance companies. I will now turn it over to Julia Harvey to talk more about some other legislation.
Good morning, everyone. So I'm here to speak this morning with you all about another piece of legislation that this office is putting forth this session. And this is a bill that would establish a new authority allowing the Attorney General to petition the Superior Court to place into receivership a hospital that is in financial distress, that is being seriously mismanaged, or is otherwise being operated in a way that is having a detrimental impact on patients. This legislation is about protecting patients and our healthcare institutions and about being able to respond in the event of a crisis. When a hospital is placed in receivership, it allows the court and a court-appointed receiver to step in to protect the assets of the facility to the best of their ability and to ensure that the facility is being managed in a way that is protective of patients. As was highlighted by the Attorney General, we have put forth this legislation because of what we have learned through our hospital oversight role. We have seen most recently, and in particular through our experience overseeing the charter care hospitals under their ownership by Prospect Medical Holdings, the consequences of private interest-driven financial mismanagement of our healthcare institutions. Further, we have seen elsewhere the closure of facilities previously owned by Prospect and by Steward Healthcare in other states. And to us, all of this emphasizes the importance of providing a mechanism for the state to step in and petition for receivership in order to protect our hospitals and the people who rely on them. And certainly this office has been able in the past to take action to support our hospitals within the context of our hospital oversight authority, so within the context of hospital transactions. But let's remember, most of the time hospitals aren't being bought and sold. They're operating in the normal course. And so if there is a hospital in crisis in Rhode Island in the future, this legislation would allow the state to take action whenever it would be necessary. And I also just want to say again that we are grateful to Representative Susan Donovan for her leadership in sponsoring this legislation, and we thank the General Assembly for their consideration of this important bill. And next, I'm going to pass it on to Sarah Weiss.
Thanks, Julie.
And I'm here today to talk a little bit about the Attorney General's Public Protection Authorities bill. This is a bill that is coming out of our lived experience as attorneys on the ground working for Rhode Islanders every day to try to correct unlawful practices by businesses and government throughout the state. These are gaps that we've identified and that would enable us to undertake more pre-suit investigation and to be able to resolve problems that are cropping up for everyday Rhode Islanders quickly and effectively. And it's relevant to healthcare for a few reasons. Because it would give us the power to engage where a business or a government entity is engaged in pattern of repeated illegal acts. This would allow us to enforce healthcare laws that don't fit into any of our other authorities. That might not be a consumer transaction. It might not be another one of the specific laws that has mentioned the Attorney General's name. There's two main applications of this in the healthcare realm that we've identified that we could use this authority for. The first is private equity in nursing homes. We have seen over and over private equity come into Rhode Island and want to buy nursing home licenses. And in the course of doing so, a responsible private equity firm would disclose their related transactions, different companies, so that the regulators could evaluate whether that's going to be the best deal for Rhode Islanders. But as of now, we have seen that this does not always happen, and private equity is not always following the law. And where that occurs, we would like to be able to take action to address it. For example, we know of an investigation of a private equity-owned nursing home in another state, and they also have facilities that are here. But we can't undertake that investigation without the proper legal authority, which this bill would give us, to be able to prevent something that's happening in another state from being repeated in Rhode Island. The second really big area is where the federal government has passed laws that help our healthcare system, that help consumers access healthcare, receive equitable services, and is no longer going to be enforcing those laws because of changes with the federal government. So you have all seen our work trying to restore federal funding to our healthcare system, to our state agencies and researchers across the state. This is part two. What do we do when those federal agencies are no longer enforcing the laws that they were entrusted with? This bill would give us the authority to enforce those federal laws. One example of that is the No Surprises Act. This was a big piece of congressional federal legislation that bears directly on healthcare pricing and consumers' right to transparency and information about the costs that they pay for healthcare. So with passage of this bill, our office would be able to enforce that law directly and get the benefits of the laws that are already on the books. So it doesn't give us any sort of unrestrained authority. It just says someone's watching the store. The laws that the General Assembly has passed or that Congress has passed, that the people's representatives have enacted, can now be enforced. And that's a great thing for the many Rhode Island businesses that work really hard every day to conduct their businesses in a way that follows all of the relevant laws. So we would like to be part of that fight, and this bill would help us get there. And we would, of course, like to thank Representative Morales and Senator LeMoyne for their sponsorship of this legislation. And now we're going to transition into regulations. So Steve Pravazza is going to tell you about that one.
Thanks, Sarah. Good morning. My name is Steve Pravazza. I'm responsible for overseeing our office's antitrust enforcement, and the Attorney General, as our state's antitrust enforcer, is responsible for ensuring that proposed transactions, and including in the healthcare space, will not risk Rhode Islanders' access to affordable, quality healthcare. One of our biggest challenges in this space is that we often don't know about healthcare transactions before they take place, unless they involve a facility or they're large enough to trigger federal reporting requirements. With that in mind, yesterday our office issued a proposed rule that would require healthcare transacting parties in a healthcare transaction to notify our office if there's a material change to their organization or they're being acquired, including by a private equity investor. The rule would require the transacting parties to provide our office with notice of the transaction, including the type of transaction and basic information about it, so that our office can determine whether further investigation is necessary or whether we need to intervene to prevent the transaction. So this proposed rule is now live on the Secretary of State's website. We urge members of the public and the healthcare community to comment on the proposed rule. We take comments on the Secretary of State's website. You can write to us. There will also be a public hearing on the evening of July 8th, where there'll be more information on our website about how to attend the hearing and how to submit a comment. The public comment period will close on July 23rd. And with that, I will turn it over to my colleague, Mr. Hoffman.
Thank you, Steve. Let's see if we can get caught up here. Oh, all right. And so, thank you, Steve. I'm Keith Hoffman, the Chief of Policy to Attorney General Neronha. And as the Attorney General mentioned, I'm going to speak about an advance notice of proposed rulemaking for artificial intelligence guidelines. Artificial intelligence is, as you all know, really changing our economy, changing many, many aspects of services being provided to Rhode Islanders. And it can be a good thing, and it can be a very dangerous thing, especially in healthcare, where patients' lives are literally on the line. Let's talk about the good things that AI could do. It could make providers' lives easier by helping with medical notes. It can help to create health systems that are efficient and intentionally designed to be free of bias, but it can also be very dangerous. These tools are designed by people, and people can make mistakes, people can be biased, people can have motives that run counter to the interests of our patients, our providers, and our healthcare system as a whole. For example, AI could be a powerful new tool for insurers to deny claims or otherwise exclude people or groups of people from access to healthcare they're entitled to. Relatedly, some companies may overstate the effectiveness of their AI tools, which can create special risks to healthcare providers and patients who are relying on these tools to provide and receive healthcare. So through the Deceptive Trade Practices Act, our office has the authority to regulate in this area if necessary and valuable for Rhode Islanders. And so we have opened an advanced notice of proposed rulemaking. It's not a formal rule that's been designed. It is just an opportunity for Rhode Islanders to provide input, to tell us whether, and if so, how we ought to regulate AI in healthcare and in other areas, including housing and employment. The comment period runs until July 23rd, and there will be a hearing on the evening of July 9th, the day after the hearing for our pre-merger notification rule. Information about how to attend that hearing will be available on the website. Through this advance notice of proposed rulemaking, we want to ensure that no community in Rhode Island is unfairly impacted by any bias or deception regarding artificial intelligence, and whether regulation can help to make AI a tool for good, and only for good, in Rhode Island healthcare system. Thank you.
Now I would like to explain a little bit about the complaint that we filed late last night, and that will be available on the public docket this morning. We in the Attorney General's office have brought this piece of litigation addressing pharmacy benefit managers, and we heard the Attorney General tell you a little bit about why. Pharmacy benefit managers are basically the middleman of the drug industry. You have a manufacturer, the pharmacy benefit manager, your health plan, and then the consumer and the doctor are somewhere over here. The pharmacy benefit manager makes contracts with both the manufacturers and the health plan, and through those contracts purports to, as we allege in our complaint, and represents to both the public and employers who run their own health plans, or insurers that run their own health plans, that they are going to be able to save the plan and consumers money and make sure that there's a clinically appropriate use of drugs. The PBMs and the group purchasing organizations that are defendants in our suit are listed here on the slide. And the allegations in the complaint set forth in detail how these organizations don't live up to those representations of cost savings and clinical effectiveness. And we, again, like we try to do with all of our actions, took this action because of information we learned about how Rhode Islanders are affected by high drug prices. This survey result that you see behind me was particularly shocking to me, that because of high prescription drug costs, Rhode Islanders are actually skimping on their own clinical care because they can't afford it. They're so high that people who are already paying a large percentage of their salary in health insurance premium can't afford that co-insurance, that high deductible. When they go to the pharmacy and say, hey, I gotta fill this prescription, they might not be able to do it that month because of rising costs. So we've heard about that in our office. The other source of complaints from our office have been the independent pharmacies in Rhode Island. And to their credit, many independent pharmacies have come forward to our office to let us know that the reason that they're having a hard time staying in business and allowing you, the consumer, to avail yourselves of their special services. A lot of independent pharmacies are community-based. They have services for the disabled and the elderly. They have vaccination services and other special community-based programs. And a lot of the reason that those pharmacies are going out of business at such a high rate is exactly this story, which is one that came into our office, that a pharmacist was only getting reimbursed for $400 less than the acquisition cost of a drug, and knew that the CVS pharmacy, the same brand as the pharmacy benefit manager in that case, was getting reimbursed significantly more. So with this kind of unfair practice, our local pharmacies don't stand a chance, and as alleged in the complaint, they're closing at a precipitous rate. The complex and opaque nature of drug pricing in the United States is what allows pharmacy benefit managers to engage in this conduct. And these, again, are summaries of the allegations in the complaint. This is one such example that stood out to us when we were rereading our allegations. And this comes out of some testimony that actually Novo Nordisk's CEO gave to Congress. And as you can see from this numeric example, that Ozempic, which is one of the most popular and most high-priced drugs in the United States right now, the list price, or it's called wholesale acquisition cost, very, very opaque and hard for consumers to understand, is $969 per month, whereas it's only $122 in Denmark and $59 in Germany. And this price difference makes a really big difference out of pocket. You would only pay $24.40 if you were in Denmark, but in the United States you're going to pay $193.80. And here, the role of PBMs in this story, as stated by the CEO of Novo Nordisk, is that it's rebates that are pushing up the price in the United States. In Europe, one of the differences, there are a few, but one of the big differences between drug prices in Europe and drug prices in the United States is that in the United States, PBMs demand rebates. So in order to get the savings that PBMs represent that they will pass on to plans and consumers, PBMs demand rebates of manufacturers. This is like a rebate that you might get on a sale item. They basically say you have to put your drug on sale if you're going to sell to us. But what that does is it causes manufacturers to raise the initial price so that they have the margin to offer that sale. So the pharmacy profit is level, the PBMs take a portion of the rebate, the health plans pay more, and consumers pay more. All of this is set out in much better detail in the complaint if you are ready to read over 200 paragraphs of allegations. So we filed suit under the Deceptive Trade Practices Act here in Rhode Island because this behavior is harmful to consumers. It has a direct pocketbook effect to any consumer that has a deductible or co-insurance when they go to the pharmacy, which is most of us, or even those that have tiered drug pricing with their health plan, because which drug is on which tier is controlled by the pharmacy benefit managers, the deals that they're able to strike behind the scenes with those manufacturers, and what profit they can take from this transactional system. So we brought 3 counts of violation of the Deceptive Trade Practices Act to seek remedy for these violations. We're looking for injunctive and monetary relief, and we are just beginning the journey today with this lawsuit. So we are hopeful that as we continue to pursue it, that we will be successful in driving down drug prices in Rhode Island. So with that, I think that actually sums up our things that we have done, but we have some future announcements for you. And so I am going to turn it back over to Julia Harvey to tell you a little bit more about our future work.
Great, thank you, Sarah. Great to see you all again. So the piece that I would like to talk to you about now is another announcement that the Attorney General previewed at the top of this time, which is that we are excited to announce that this office is entering into a new partnership with researchers from Brown Center for Advancing Health Policy Through Research, or CAPER for short. And we are partnering with them on 2 new research efforts focused on the Rhode Island healthcare landscape. First, we are partnering with CAPER to explore opportunities for systemic healthcare reform in Rhode Island. The goal of this is to improve access to equitable and affordable care. And to that end, today, we are releasing an initial analysis by the team at CAPER, led by Professor Erin Fusay-Brown and Hayden Rookleigh, examining a suite of policy options for Rhode Island to consider that would move the state forward toward a universal health care system. That report, as with the other things that you've heard about this morning, is available on our website for you to dive into the details. But just to contextualize this report a little bit, Rhode Island and the country as a whole operate within a highly fragmented healthcare ecosystem. And it's characterized by a suite of complicated public and private health insurance payment systems that often, well, they do a number of things. They lead to high costs, they leave some people uninsured or underinsured, and they create serious burden for our providers and for our healthcare systems. The goal of a universal or a single-payer healthcare reform healthcare system is to achieve universal coverage and access for all Rhode Islanders, to promote affordability, and to create financial sustainability and administrative simplicity in the administration of our healthcare. The report, just to give you a high-level overview, it puts forward 4 proposals that are informed by CAPER's deep expertise in the health policy landscape, and also their awareness and understanding of how efforts for universal and single-payer healthcare reform have been attempted or implemented across the country and in other states. The first proposal is the most comprehensive, which is a state-based single-payer plan. And this would provide universal coverage through a publicly financed plan and standardized insurance coverage for all Rhode Islanders, creating a unified payment system. A second option that is put forward in this report is a comprehensive public option that would create a state-administered public option plan and would essentially compete on the marketplace with other insurance offered by our private insurance system. A third option is a pricing parity model. You know, we talked earlier about, we see these vast differences between the way that Medicaid is reimbursed and the way that commercial insurance is reimbursed. And the idea of this model would be to bring the reimbursement across those plans level, to bring up Medicare rates with the option of controlling commercial rates as well. And lastly, this report sets out an option for a state prescription drug purchasing pool. We've talked a few times today about the high cost of drugs and the impact that that's having on Rhode Islanders. And this option in this report would offer a new state-run prescription drug purchasing strategy with the goal of providing drugs at a lower cost. And each of these options, which as I said before are detailed in depth in the report, they would move the state directionally toward universal coverage while balancing, varying degrees of complexity and costs and policy trade-offs. Because as the Attorney General said at the top, this is tough. Solving healthcare is a hard problem and it requires careful thought. I will say about the report that while other, universal and single payer options that you might be familiar with, Medicare for All is something I think we have all heard about at one time or another, where those options are often being discussed on the national stage, this report is really looking at what are opportunities to move toward universal coverage in Rhode Island at the state level, which we think is an exciting opportunity for us to take a look at. And I will say at this point, this report does not specify a preferred policy option at this stage. This report is the first phase of an effort that we are undertaking with CAPER, and it will be followed by an in-depth financial analysis to help us, to help the state of Rhode Island, to understand the potential financial impact of one or multiple of these options, including what the cost would be and what the savings opportunities are. And we really do look forward to continuing this work and sharing the results of those efforts with all of you. Finally, the office is also announcing a second project that we are undertaking with the CAPER team, which is intended to help us better understand barriers to primary care access in Rhode Island, which is something, as we have said, is really top of mind for us here. And we look forward to sharing more information about that effort in the near term. And next, I will turn it back once again to Sarah Rice.
So at this point, we have really extensively discussed the problem and some of the solutions that we can bring from the Rhode Island Attorney General's standpoint. But we know, and the Attorney General previewed this, that the next steps in healthcare are going to take thoughtful, data-driven thinking that we can't produce here at the Attorney General's office. And unfortunately, our state agencies are not equipped with the personnel and resources to do that work at the moment. So we are also announcing our future work in proposing a new healthcare agency, that this state agency would be better positioned to undertake some of the solutions to the problems that we have identified here today. And in particular, the new agency will take on certain of the existing regulatory functions and break down those silos that the Attorney General mentioned in his opening speech. It would coordinate closely with other key healthcare departments and agencies to make sure that we don't just replicate some of the issues that have happened in the past when departments and agencies have been reconfigured. And it would be given new authorities to develop and implement policy solutions. Basically, this agency would be like those agencies in Massachusetts, Vermont, Connecticut, and Maryland that are dedicated to driving health policy through data collection, analysis, and sophisticated policy work. And these are things that we need to undertake that more complicated planning and big projects like what we are seeing and proposing in the CAPER study. These big ideas take a lot of policy work behind the scenes to implement. Rhode Island already has many dedicated public servants here and elsewhere in the state that are doing this work. But to take on the new challenges that are facing us, even as Rhode Island has often been a healthcare policy leader, we know from all of the stories that you've heard here today that healthcare isn't working as it should here. And to take on those new challenges, we need to add capacity. We need to make sure that Rhode Island's next steps are efficient, well thought through, and are supported by data. We basically cannot afford, with the system so fragile, to undertake new projects and proposals. We can't take those investments and put them into things that are not going to work. We need the future planning, looking not just 5 years down the road, but 10, to be able to course correct on some of the systemic problems that we have seen that are leading to a healthcare system that is in crisis. So look forward to more on that, and we can see here our new website. And with that, I will leave it to the Attorney General for questions.
Thank you, Sarah. Well, I want to thank the team. As you can see, they've been working really hard. They spend a lot of time with me, more than any group in the office, and I apologize for that, guys, but they're working really hard. And what we have laid out today are action items. We're bringing a lawsuit to drive down drug costs. We're proposing legislation that the General Assembly can take up and pass to stabilize primary care. We're going to issue regulations that will help us make sure that some of the potholes that we've seen, more than potholes, chasms that we've seen, we'll be aware of them and we can take action about them. We've got to rethink the way we're insuring Rhode Islanders because what we've got isn't working. And so we need better thinking and we need real action to solve a problem that exists. Look, when I went to Brown and spoke to Brown ER doctors who had 50 patients boarding in Brown Health ERs, and I told, and they're frustrated. That's not good for patients, and it's not good for them, and it's not good for their workers, those great ER nurses and other providers. I said, look, it's going to take spectacular failure for us to fix this problem. And they said, we're in a state of spectacular failure. When we look, Prospect, Roger Williams and Fatima, we're on the edge of a knife there. We're on the edge of a knife as to whether they survive or not. And if they don't, there will be one reason why not. Because we haven't acted quickly enough, notwithstanding that the evidence has been there in front of us all this time. When I was sworn in as Attorney General for my second term, I talked about two things in my remarks, other than my family. One was climate, which we're not doing enough there either. The other was healthcare. And my words were, we have to fix healthcare. And we're 2.5 years out from that moment, and we still haven't fixed it. We don't have time not to act. We must act. This is the beginning of how we save healthcare. It's not the end, but we need to do it. The people standing behind me, like, some people think I come up with all this stuff. I don't. They bring me great ideas. And I usually, what do I say? Go. And then they look at me like, don't you want more? And the answer is, I trust them. They're extraordinary public servants. They're led by extraordinary public servants, and Kate Sabatini and Dee Goldstein, whose fingerprints are all over this too. If we have the courage to do what we're talking about today, we can drive down costs, enhance revenue, and give Rhode Islanders the healthcare system they deserve. Nobody should walk into a hospital with a brain aneurysm and learn that the MRI in the facility isn't working and is sent home.
Peter, how much will it cost to raise the Medicaid reimbursement to the Medicare level, and where will that money come from, particularly with Republicans in DC looking to change Medicaid?
Yeah, so I think there are a couple of answers to that question. First of all, we think, EOHHS is going to have to run those numbers in the Medicaid office. That's what they do. I can't speak to what the match will be because I don't know what that number is, but we estimate in the $50 million range to be conservative, right? That's a lot of money. So where does it come from? Well, first of all, let's start with this principle. That if we're sitting down and building a budget today, and look, the governor found $10 million yesterday, as you reported, right? So you can find it, right? But if you're sitting down and you're doing, that was for Roger Williams and Fatima, apparently. So we can find it in our state government. We got a $14.2 billion budget. But when we're building that budget, where do we start? Where do we start? What do we know is necessary? Let's do a poll of Rhode Islanders and ask them what should be at the center of our budget planning. And I guarantee you, healthcare will be in the top 5, maybe in the top 3. So that's where we started. So you go back to the beginning and you say, it's not optional to pay for it. Where do you find it? And there are ways in the budget to drive that revenue. I asked Keith, poor fellow, Saturday I called him. I said, Keith, find me $100 million. And he paused. And then he found it. So look, I don't want to speak for the speaker, but I've had conversations about him, with him and his chief of staff about where we can find the money. But the principle here is, it's not optional. It's not optional to fix healthcare. I don't think Rhode Islanders think it's optional.
One
And
more.
if that means pulling money from somewhere else, then we need to do that.
One more, you say, you've been talking about healthcare for a long time. You talked about your second inaugural remarks. You were involved very much with Prospect and the situation there, but why is it taking years to get to this point where you're promoting more tangible action steps?
Yeah, I think we have been proposing them along the way, Ian, but I will tell you, we don't control the levers of government. So first of all, building a case against the PBMs, I mean, that 200 paragraph complaint wasn't built in a day. So some of these things take time. Litigation, to prepare for litigation takes time.
Hey,
I just want to finish that answer. I had better hopes for some of the hospital association legislation, which would have included helping primary care, but my optimism on whether that'll make it is lower. And so we proposed our own legislation using Senator Laurier's legislation for pediatrics as a model. That's a way to get in right there and fix it. Some of it is the team is stronger. Lee Staley, who's our new healthcare chief, who came up with that concept, working with the team. We just hired from HHS. He, like me, was sort of fired by Trump to our benefit. So some of this is a work in progress. The HMA study we commissioned in 2023. We just got it. We just finalized it recently. We've recently started to partner with CAFR. But look, this could have been solved a long time ago, simply by raising Medicaid rates. And finally, we just decided we're going to put the plan out there, and here's the path, and we can choose to walk it or not. But if we don't walk it, Rhode Islanders are going to suffer.
how do we prevent long-term health care facilities, for instance, from keeping higher Medicare reimbursement as profit
Yeah.
and high salaries for management and not to people?
Yeah, well, that's one of the things we have to think about, not only in that space, Steve, but also in the space of, look, primary care practitioners would prefer to practice independently. Take Anchor. I mean, they didn't go out of business because they were mismanaged. They went out of business because of reimbursements. You can't make money in primary care. You can't break even. That's why Brown Health and Care New England are subsidizing their doctors. So the same is true in that legislation, which is why we had a caveat to our support of the Harry legislation, because we want to make sure that now that the docs are largely inside big health systems, we don't want the money to go, that should go to primary care, to go, as much as I love the neurosurgery wing, to go to the neurosurgeons, right? So we have to make sure that we account for that, and we will. And the same is true when it comes to primary care. It's why we want to be able to get inside the books, inside these nursing homes. And if we see that problem, bring an action. Look, I think what allows us to do a lot of the work today, we owe the legislature a debt of gratitude, because when we started, our consumer protection bill would not have allowed us to do much of the work that we're doing today. It would not have allowed the Attorney General to act in this space. We want the tools to act. Now, that public protection bill that we talked about, that Sarah talked about, that passed the General Assembly last year. As Sarah indicated, boots on the ground, see investigations we should be doing. The governor vetoed it. I don't know why he vetoed it, but you're hearing it from the people who do the work, not from me, okay? That there are investigations we could do that are going on in other states that we don't have the tools to do, notwithstanding that the General Assembly passed them because the governor vetoed it. So who's out there to protect Rhode Islanders? It's this team behind me. They're extraordinary public servants. Yes?
On the new agency front, how would this new agency not duplicate efforts of HHS and other departments?
Yeah, so what we envision, and you'll hear more about this in the fall, it would take components of those current agencies and basically put them back together in a different way and give them more authority and a different additional mission. You don't get a lot of, if any, strategic thinking coming out of RIDO, or OIC does it in their space when it comes to insurance rates. But beyond that, they say, well, that's not our lane, right? So they're very siloed. The Medicaid office, they're having a hard time keeping up with paying claims. instead of spending more time on strategy. It's not a criticism of any of those public servants. What it means, though, is that if we consolidate those missions in one place and add a strategic component, all of their decisions or recommendations to the General Assembly will be informed by data that right now we don't have. And that's some of our struggle too, is to get data that we need. And that's been one of our, for example, we wanted to know more about one insurer's network, see whether Rhode Islanders really could find a doctor. We were looking for that data, we didn't have it. So we got on the phone and started making calls. We shouldn't have to do that. That should be something that someone in the state knows. Like, is the, OHIC should know it. Is the network adequate? Meaning, when I sell you insurance, are there enough doctors? That's the insurer's obligation, but we don't know whether or not it's adequate until we start making phone calls. It's one of the reasons we want to pursue that.
Would expanded authority to enforce unenforced federal laws allow future AGs the ability to, for instance, charge for cannabis use or enforce immigration laws?
That's a good question. I haven't thought about it in that context. I really only thought about it in the context of healthcare. But we saw in Trump 1, where, take for example the work that we did involving the recycled metals facility where they were shredding cars in Johnston. Federal government stepped away from that case. We stepped in. We really want the authority to step in when the federal government abandons the field. I don't see that. I don't see that in immigration, and I can't imagine that authority would be applicable there. Yes. Hi.
Slightly off topic, United Healthcare sent a letter to people who have Medicare Advantage stating that their current contract with Brown University Health is ending in July.
Mhm.
Do you have a message to those two companies, and are you concerned that if they don't reach an agreement that people won't be able to find doctors that will be able to take them considering this healthcare crisis?
Yeah, look, I'm concerned about that for sure. My message to the parties is, get in the room, work it out. I can't work out their labor issues or contractual issues for them, but they do need to work it out. It won't help our healthcare primary care crisis for sure. So my message to them is work it out. Look, this is the posturing that sometimes happens as people are trying to reach agreements. What's important in a sense is that in the marketplace that they have, that nobody dominates the marketplace. In the past, we've seen a situation where insurers, I believe, are dominating the marketplace. This is why we're looking at new ways to insure Rhode Islanders, because we don't think the market is working. It's an artificial market. There's so many governmental and other constraints on the market as we have it right now that we think Rhode Islanders in the end suffer. So we're really, the team and I are really fascinated about what our work with the Brown School of Public Health will produce, hopefully in the very near term, to figure out, look, is there something we can do differently? And look, if nothing else, that applies pressure on the current players to live up to their obligations to Rhode Islanders. They're not indispensable. And so they may find out that they are replaceable if they don't step up to the plate. And again, I'm grateful for Blue Cross for being in discussions with us to step up to the plate more than they have. They have taken steps, but we're hopeful we can do more.
Thank you.
You're welcome. Hey, Lynn, sure.
I just want to publicly say thank you to you, your office, your team. You have answered the call that I have been screaming about for years. As a nurse of 41 years, our healthcare system is collapsing around us. We can't keep going in this pathway, and you're the only one that's taken this challenge and moving it forward. And for that leadership, I thank you, my membership, thank you.
No, thanks, Lynn. Appreciate that very much.
Should a worst case scenario happen and none of these legislative efforts come to fruition and pass the General Assembly,
Yeah.
what do you foresee as consequence?
Yeah,
As you're
look, I
near-
think the reason why, I think we could see a hospital closure. I hope not. One of my concerns with Roger Williams and Fatima was even after they got out of bankruptcy and they got the $50 million that we squeezed out of Leonard Green to give to them as a head start, because they have no endowment, is with these low reimbursement rates, will they make it for 2 years? Now, the good news is, very low level good news, is if there's a insolvency event, they'll be in a Rhode Island courtroom and not one in Texas. That was a significant concern to me. I'm glad we're able to hopefully extract them, and I hope the deal is as constructive will go through. But you can certainly see that. Look, it's only going to be harder for Rhode Islanders to find doctors if we don't make primary care economically feasible. Look, if you're a doctor coming right out of residency, right, and you have on average $250,000 of medical school debt, you know, our loan forgiveness program is currently constructed is going to help maybe $400,000 going to help one doctor. So you really can't count on that writ large. So if you can make 30% more in Westport, Massachusetts than you can make in Newport, Rhode Island, where are you going to go? You know, you're still, if you are a Rhode Islander, you're close enough to home, but you're making 30% more. And people have to think about that if they're coming out of school with that kind of indebtedness. That's not a small amount of money. So we have to make it attractive for them to come here. It has to be equal. If we're competing on an equal playing field, we can get them here. Like I dragged my wife here from New Jersey, and I don't think she regrets it. She may, well, I won't say what she might regret, but you know, we can make it attractive. And one of the things I've suggested to some of the insurers is, you know, realign the mix that you're paying to specialists. They won't like it if they take less and primary care takes more. That's a way of using the same pool of money if we're willing to be bold in that space. But look, we have to bite the bullet and appreciate and understand and commit that healthcare matters. And it matters enough. Look, we don't think about healthcare until we need it, right? We don't think about the system until we're in it, until we need it. One of our loved ones is. Lynn lives it, and her team lives it, but we don't. And then all of a sudden you're there, and things don't go, and you say, well, how can that be? Like, why are Rhode Islanders walking out of ERs? They don't want to wait 12 hours. Why are they going there in the first place, some of them? Because they can't find a primary care doctor. All of this is fixable. I know Thunder Mist is here, and they understand this dynamic, so thank you for being here. Thunder Mist provides all the primary care services for Landmark. So when we talk about Landmark, yeah, they do okay, but they're not subsidizing their primary care doctors the way Brown Health and Care New England are, to the tune of $150,000 a year. So you really, when you hear about, when people make statements about what's the model, and Landmarks, I visited them, they're fine. I had a great visit. But you have to be careful and you have to think. When people say, you know, this will work or that will work, you really have to test it. And I'm really grateful to the team back here for not only testing sort of my ideas, but testing what we hear. So for example, what we hear, when I talk to doctors, 50 doctors a week or so ago, well, you know, Blue Cross is raising rates, reimbursement rates for fee-for-service, but some of the value-based payments are coming down. So you got to understand both, right? Where does that balance out? And so, you know, that research and thinking will continue. Other questions?
Brief aside.
And then I'll come to you. I promise.
On the prior auth front, what is the precedent for this sort of act of eliminating prior auths?
Yeah,
if any?
you know, I think we, you know, the team could answer this better. Jordan, was it you who talked about prior auth? Yes. That's not bad. Would this be sort of precedent setting around the country?
There are other states that have taken action, like Vermont has a pretty comprehensive reduction of prior auth, but this would make Rhode Island a leader. This is a bold piece of legislation, especially the prescription drug elimination. This is from feedback from providers on the ground as things lie in Rhode Island, that this is the legislation that they need.
Yes.
I think part of the other side of the conversation is like the rising cost of healthcare across the board is growing faster than the economy, faster than wages. I'm wondering if your office has considered or has the authority to make any changes in order to rein back the rising cost of healthcare.
Yeah, you know, I think that is a legitimate question. How do we keep costs down and bring revenue up, right? Drugs are something we can control. We know that, you know, if you look at the complaint, some of the graphics, we didn't share them here, but some of the graphics in the complaint will show you the degree to which PBMs are driving up, as we allege, driving up drug costs. There are other ways to make healthcare more efficient. Part of it is build primary care to the point where people aren't showing up in the ER. ER care is very expensive. There are pretty simple ways we can do it, but we're not investing where we need to make this work. And part of it is, you know, healthcare's hard. It's hard. It took me a long time to be able to speak about it somewhat, I hope, capably.
A lot of people are afraid about doing anything that makes CVS mad because they're afraid they'll leave the state. I mean, legislatures in Woonsocket and the state
Yeah.
don't do anything. So what is your thought about that, because you're suing them outright, and it's
Yeah.
a free money machine for them, so.
Well, look, we approach everything that we do with a couple of things, and this same is true really of the Trump litigation, which some of these folks are working on, which makes their lives even busier than it would be otherwise. We think about, is there harm? Is it unlawful? And do we have standing to do something about it? And whether it's Donald Trump that we're talking about cutting off federal funding or other things, and birthright citizenship and others, same proves to be true here. As U.S. Attorney, look, you know, we prosecuted the Speaker of the House. We executed a search warrant at his home at 6 o'clock in the morning at the Speaker's office, I don't know, later on that morning, search warrants. He was the most powerful man, the Speaker's the most powerful politician. We didn't care, we went, because it was the right thing to do. CVS and the other two, Optum and Express Scripts, are part of the drug price problem. And it needs to be addressed. And my hope is that they'll be the responsible corporate citizen that they have been, and step up here and make this right. And I think in the end, I have confidence that they will. I mean, I understand that they're a hometown team, part of a hometown player. But sometimes a hometown player needs to learn to follow the rules, right? You take them out of the lineup and, you know, then they learn that they got to run all the way to first base, then you put them back in. Well, CVS has to run all the way to first base. Anything else? If not, thank you for your patience. I know this was a long one. And thank you, team. Oh, and I want to thank, one last, sorry. I don't want to forget my thank yous, not only to the team, to the General Assembly for passing the DTPA, which we're relying on, but the people behind me wouldn't be here had not the late Senate President and the Speaker given me the FTEs to fill these spots. At least half of the people standing behind me wouldn't be here, and all of this would have taken twice as long. So I really owe them a debt of gratitude for investing in this office in 2023. And I hope they'll invest a little bit more this year to keep building out this work, because it really is important to Rhode Islanders. I wanted to make sure I included that. So thank you all for coming and your patience and your time. And if you have questions for the team, members of the media, we can certainly make them available to you. Okay? Thanks, everybody. Thanks for your patience. Thanks, Senator. Thanks, team. Great work.